So is Dr. Anumeet Bagga ready with her presentation? I think you are one of the rare surgeons who are specialized into endovascular right from the
All
beginning of your
thanks to
career.
you, sir. I've been attending this APVIC for the past 4 years now. Good evening, everyone, and thanks, Dr. N. Khanna, for letting me be part of this APVIC, and it's a very great honor. So, um, I start with my presentation. So, I have been doing a lot of interventions here at my institute, which is Government Medical College at Patiala. But I have been doing open procedures also. So, the critical limb ischemia, which is characterized by chronicity, which is more than 2 weeks of duration, with ischemic rest pain, non-healing wound, ulcers, or gangrene in one or both of the legs, which is objectively proven arterial occlusive disease. The diagnosis is both the constellation of signs and symptoms, and for making the diagnosis of CLI, which is more on the duration. So that is the main focus. So according to task classification, the task lesions are amenable for endovascular therapy. For the type B lesions, we prefer the endovascular. For type C, the preferred treatment is the surgery. But for type D, the open surgical procedures are recommended. But as the interventionists are we going for the endovascular therapies and they're becoming more advanced. So, but still, there are many cases in which the endovascular therapy is not possible. So, the open surgical procedures can be classified as either the direct anatomic, which includes the aortobiofemoral bypass, aortoiliac endarterectomies, descending thoracic aorta to femoral bypass, iliofemoral bypass. The extra anatomic bypass are axillofemoral bypass, femorofemoral bypass. The femorotibial artery bypasses with prosthetic graft material should not be used for the treatment of CLI because they have very high rates of graft failure and amputations. The bypass to the popliteal artery with autogenous vein is recommended, which is in preference to the prosthetic graft material. So I'll be discussing a few cases. This was a 50-year-old male with the history of intermittent claudication in bilateral lower limbs, right more than the left for the past 8 months. And he also had ischemic ulcers over the right leg and foot for the past 6 months. He had a history of CVA in 2010, and he's also known case of CAD. He's a non-smoker and he is a non-hypertensive and a non-diabetic. So this was the case. He presented with the ischemic ulcers on the right foot, and this is post-open surgical procedure. These are the CT angiofilms, which shows complete block of right external iliac, CFA, SFA, popliteal, and there was partial filling of the right profunda. So when I opened the external iliac, the right groin incision was made, and right iliacs were exposed. The right common iliac was healthy. The right external iliac was hard and cord-like. The right CFA, SFA, and profunda were completely occluding the lumen, and thromboendarterectomy was done. And then right iliofemoral bypass was done using 7 mm EPTFE graft, and femoropopliteal PTI bypass graft was done using the reverse saphenous vein graft. So the inflow was from the right common iliac, and the outflow was into the right common femoral artery. There was another case who presented with complaint of left toe gangrene for the past 20-25 days and had also history of intermittent claudication for the past 3-4 months. This patient was a diabetic and a chronic smoker. And this is the CT angiofilm, which shows complete complete opacification of the left external iliac from its origin, and the reformation of the left SFA and profunda by the collaterals. A hybrid procedure was performed using a femorofemoral bypass graft with 8 mm EPTFE and balloon angioplasty of the left distal SFA and popliteal artery. So, and another case, this is a 90-year-old male who presented with the bilateral intermittent lower limb claudication for the past 4-5 months and left foot gangrene for 1 month, which was progressively increasing. There was no history of smoking, diabetes, or hypertension, but when he presented, he was in AF. The 2D echo was normal. So this is the case. I attempted an endovascular procedure going from a crossover right femoral approach, and while doing the procedure, this somehow at the aortic bifurcation, the O14 guide wire got stuck in the crossover sheath, so it could not be extracted out from the right femoral puncture. So I had to open up the left femoral groin, and then the wire had to be extracted from there. So I don't know how it came, but it did, and it was a complication that I had to deal immediately with. So this was done. This was another case who presented with history of uh, bilateral intermittent lower limb claudication of 2 years duration. This case I've been planning for axillobifemoral bypass graft. So I would just thank you at the end that these are the cases that I've done as open procedures, which was I wanted to share. So thank you very much.
Doctor, just for my interest, can you tell us which patients you decide to go for surgery in similar situation, and when you take, because you have got both advantages of interventionalist and a surgeon. So how you decide where to go for surgery and where to go with intervention?
This is basically, sir, based on the comorbidities. If the patient is, I said, as the patient was a 90-year-old male, so I could not go for an open procedure. So I went for the intervention and involving long lesions, which the lesions involving the iliacs and the femorals, the open procedures are preferred. The CTOs, obviously, they can go in for endovascular, but I am obviously prepared for the open procedure as well, as the complication occurred, I said, as I mentioned. So I had to open up the left groin and extract the wire. So, but then, yes, we had the facility to do it. So I did that immediately.
So you have an advantage of being a surgeon,
Right.
and I would say you have a disadvantage that because you will not try very hard to do a difficult lesion, like a cardiologist or somebody like Dr. Shri Lata, she would be continuing to pursue further for finding ways to cross that lesion and to do it. And many times, like in cardiology, we do it, CTO, it takes much longer and we manage to do it. So I think for you, it might be easier, just you can find a way.
No, I'll just sorry, I would just want to just say something. I have been trying to do very difficult lesions also. I had for this patient, I actually did anterior tibial and posterior tibial. I crossed over and we did good revascularization. But during extraction of the wire, it got stuck. So yes, I do it very patiently, and I've been trying to do as much crossing the lesions. But so it's well, I'm a cardiothoracic surgeon, so I've got a lot of patients to do those things. So that's it, sir.
Thank you. That was really very nice acceptance of the things which you have in your hand and giving and sharing your experience.
Right. Thank you, sir.